Hi, my name is Benjamin and I'll be presenting on fibromyalgia syndrome and I'll be using the word FMS. Fibromyalgia or FMS is a non-inflammatory diffuse musculoskeletal rheumatism. It originates from this word fibro, which is tissue, my, muscle, and algia, which is pain. It is a chronic pain that occurs in regular pattern on tender points and is usually generalized, as you can see on the right hand corner of the slide. It's accompanied by fatigue and tender areas in the soft tissues, which persist for more than 3 months. FMS is usually classified as a musculoskeletal disorder of the joints, yet the joints are spared. Actually, it's classified as a musculoskeletal disorder, and unlike other musculoskeletal disorders that involve the joints are spared in FMS. Incidence: 2 to 3% of populations are impacted. It occurs in 0.5% men and 3.4% females, so it's more common among females than males. Most of the patients that I saw in my clinic, actually all the patients that I that have been seen so far in the clinic were all female patients. 20% of all rheumatology visits are as a result of FMS, and it's been found by study that it's the second most common musculoskeletal disorder seen by neurologists. Most patients with FMS are between the ages of 30 and 50, some say 40, 35, 40, and 55. And the prevalence increases with age. 50% of patients with FMS have a history of sexual or physical abuse. 30% of the patients have symptoms that fit psychiatric problems like depression, anxiety, somatization, and hypochondriasis. Actually, this disorder usually has an underlying trauma um, with it. The cause of FMS remains elusive to the medical field, but some studies have implicated the CNS neurotransmitters like serotonin, musculoskeletal system, some genetic predisposition as being responsible, some endocrine dysfunction, psychological trauma, immunologic disorder, psychiatric and psychological changes. One thing remains clear about all these studies: they are inconclusive and there is no agreement. The CNS involvement. It's been found that there's an imbalance in CNS nociceptive stimuli. Now, there is a lower serotonin and epinephrine with FMS, and there's a higher substance P. Now, substance P um, is responsible for pain, while uh, serotonin modulates pain coming from the periphery to the center, which is the brain. So, in the absence of serotonin, or when there's low level of serotonin, pain is enhanced, and the reverse is the case. Alteration in CNS mechanism generates abnormal continuous stimulus. Peripheral nerve or skeletal of the skeletal system is repeatedly stimulated by pressure, and the pain is amplified at the spinal cord. So substance P released in the spinal cord goes to the brain. So in FMS, pain threshold usually reduced, therefore causing an increase in pain duration and expansion of pain field. Serotonin and norepinephrine, they are decreased in FMS. Like I said earlier, they are usually associated with depressive syndrome. Like most patients with FMS have depression, and that's why when we put patients on pain medications, we also, I mean, when we manage pain as a result of FMS, we also manage the symptoms of depression because they have an association. So serotonin and norepinephrine, they are vital in pain modulation. So their impact are mostly, actually the impact of serotonin is mostly on the descending neurons. And of course the descending neurons are the neurons that send the modulated pain uh, to kind of reduce the pain level. Now, anti-nociception is usually by serotonin. Serotonin level reduced in FMS, as I said. Administration of serotonin agonists has been found to elicit anti-nociception. The muscle metabolism as responsible for FMS. Studies have found that there is an alteration of muscle oxygen utilization in FMS, and they said that FMS sufferers have an increased muscle fatigue, reduced exercise tolerance, and that and these claims have remained inconclusive as well. Some studies also believe that repetitive micro trauma from daily living may likely be the result of the pain. But unfortunately, some studies have been made on sedentary patients, and they also found the same level of microtrauma. So this um, other study has kind of negated the other claim. And the studies also show that there is no known inflammatory component in FMS. So the use of NSAIDs and steroids may not be helpful. My patient actually, as you would see in the next few slides, my patient says that she uses Advil, and that Advil has not been helpful. Genetic disposition. Genetics have been found to play a role in chronic pain. A study by fraternal and identical twins, a study using fraternal and identical twins found that there's 50% chance of FMS, and that also 50% chance that the environment could be responsible. The study using first degree relatives found that there is that first degree relatives have 8 times chance of having FMS compared to others. So the implicated genes are the serotonin transporter, the catechol O methyltransferase, dopamine 4 receptor, and human leukocyte antigen. These are the genes that have been implicated in their genetic studies. Also, endocrine dysfunction has been implicated. Hypothalamic the pituitary adrenal axis, or known as the HPA axis. They found that cortisol of FMS patients is usually elevated in the evening. cortisol actually supposed to be decreased in the evening and not elevated, and because this cortisol is usually secreted early in the morning and it keeps rising as the day goes by. Um, so a patient with FMS has increased um, cortisol throughout the day due to lack of sleep. ACTH is released during stress, and this has been found to be elevated in FMS. And they say that that's a result of low serotonin. Growth hormone, like I said, um, is secreted in REM4 sleep. Low growth hormone in FH is seen in FMS in the evening. So, and as a result, they believe that this could be due to the elevated somatostatin. That somatostatin has an um, is an inhibitor of growth hormone. The immune system disease. The immune system has been implicated. Studies found that 17% of patients with FMS have severe rheumatoid arthritis. 30% of FMS also meet the criteria for depression, dyspnea, or anxiety disorder. So that implicates psychological and psychiatric involvement. So they even found that the prevalence of the prevalence of psychiatric and psychological involvement is much higher than in rheumatoid than in rheumatic uh, involvement. So what are the signs and symptoms of FMS? There is widespread pain, there is abnormal tenderness, there is chronic fatigue, there is stiffness, there is depression, poor memory and concentration, cold intolerance, bowel disturbance, exercise intolerance, sleep disturbance, numbness, tingling, dry skin, hair, mucous membrane. My patient is a 43-year-old African American female. She arrived to the clinic with complaints of generalized pain with excessive drowsiness during the day. The history of the present illness. During assessment, patient reports pain on back of head, shoulder, neck, thigh, and knees. She reports the pain as 8/10 with headache. She had an auto accident about a year ago and she was treated for some minor injury. She reports that her pain persisted for over 6 months with increased severity. There's occasional weakness and numbness on hands and extremities. She believes that she's not getting enough sleep, that she takes over-the-counter medication Advil, and that Advil that she takes does not really help much. The medical history includes allergy to sulfur and sulfur analogs and PCN. Migraine, history of cigarette smoking. She quit about 35 at the age of 35. She says she drinks socially. Her mother, her mother had chronic pain issue, and she is currently a mother of 2 and works at a retail store. Her vitals are unremarkable except her blood pressure, which is slightly elevated, probably due to the pain. She appears flat and anxious, very concerned about her situation. Head is normocephaly, atraumatic, no weakness or involuntary movement. Um, Tenderness was noted on palpation at the back of head. No lymphadenopathy or palpable mass. Her trachea is midline. There is significant tenderness around the neck on palpation. So thyroid was not palpated. Her chest, lungs expansion is even and is not labeled. There's no noted adventitious breath sound. S1, S2 is present, no extra sound, no clicks, gallop, or murmur. Extremity pulses are palpable, equal, and 2 plus. Her abdomen is large and round, non-tender, non-distended. Active bowel sound and tympanic, no palpable mass. Um, joint and muscles joint and muscles are symmetrical, no joint swelling or stiffness. She expressed some tenderness on during palpation around the knee. There is no focal neurological deficit. Extremity strength is 5/5 bilaterally. Skin is grossly intact. General tenderness during assessment. My differential diagnoses are: 1. Chronic fatigue syndrome. This is usually accompanied by flu-like symptoms, and the pain is not site-specific. Usually complaints of other signs of inflammation with there is usual complaint of inflammation like fever, swelling, and you know so there's no associated trauma following chronic fatigue syndrome. Another differential is rheumatoid arthritis. So there's no joint inflammation. This one usually comes with joint inflammation, unlike FMS. The pain of rheumatoid arthritis worsens if not treated. Sometimes they appear, the knees appear, the joints appear swollen, and um, and the pains are usually symmetrical. Another one is hypothyroidism. The problem with hypothyroidism and FMS is that both of them have similar symptoms. It is very difficult to differentiate the two. So, unlike FMS, hypothyroidism has no associated trauma, and the only way to differentiate both of them is by blood work. Another another diagnosis is multiple sclerosis. Multiple sclerosis comes with numbness and weakness, pain, just like FMS. Um, but the pain with multiple sclerosis may not be felt much, sometimes mild, because of the weakness of the nerves. And with multiple sclerosis, there's difficulty in walking, and the patient tends to have unsteady gait, lost speech because of the destruction of the myelin sheath. The 2010 American College of Rheumatologists SDR preliminary diagnostic criteria was what I used for my patient. And according to this preliminary diagnostic criteria, to be able to diagnose FMS, there must be pain and symptoms over the past week based on the total number of painful areas out of 19 parts of the body, that is 0 to 19, plus level of severity of other symptoms like fatigue, waking unrefreshed, cognitive problems, in addition to the number of other general physical symptoms. 2. Symptoms must last at least 3 months at a similar level, and no other health problem that would explain the pain and other symptoms. So the diagnosis for FMS is satisfied with the presence of 3 conditions. 1. Widespread pain index of 7 and above and severity symptom SS scale of 5 or above, or widespread pain index of 3 to 6 and SS score of 9 or above. And there must be presence of symptoms lasting more than 3 months and no disorder explaining pain source. Diagnostic treatment. The diagnostics that are for my diagnostic testing, definitely clinical history is very important for this patient, because patient with FMS, do not have specific diagnostic testing tool. So diagnosis diagnostic testing will tend to rule out other possible differentials. So clinical history is very important. Thyroid function test T324 TSH will be done to rule out hypothyroidism. Rheumatoid profile like rheumatoid factor, ESR, CRP, NA will be done to rule out rheumatoid arthritis. Nerve conduction test will be done to rule out MS. Spinal tap for antibodies will also be done to rule out any autoimmune involvement with MS. Morning serum cortisol, urinary catecholamine metabolites will be drawn, since these have been found to be involved in some of the studies. Then I will also do X-ray and bone scan on my patient, just to rule out any possible bone or joint involvement, in addition to MRI. My treatment for this patient will be based on the ACR recommendation and some studies. I will start my treatment with pregabalin, 75 mg twice daily. This will help the patient with pain and of course sleep, because pregabalin is a sedative. I will also start my patient on amitriptyline, which is an antidepressant, and at the same time it kind of helps has side effect of drowsiness, which will help the patient to sleep. Also, I will administer Ultram 500 mg twice daily as needed for moderate pain. I will also add Flexeril 10 mg, actually the low dose, at bedtime. Hopefully this will help with muscle relaxation. I will make referral for cognitive behavioral therapy CBT for psychological pain management. I also make referral for National Fibromyalgia Association and massage therapy. I will educate my patient about the disease process and treatment plans and expectations, on the side effects of the medication, including nausea, dizziness, addiction, confusion, weight gain with amitriptyline, sedation, cognitive impairment. I will also educate the patient on the importance of exercise in fibromyalgia, because exercise is very important to help the patient to regain some functionality, and especially the water or the aerobic exercise, and that will help to strengthen the patient health and I will also encourage the patient to at least gradually increase her activity. If she could do do exercise 3 times a week, 30 to 40 minutes as recommended by um, some of the studies. Three times of 3 to 4 times a week, and gradually increase as she tolerates. I will educate my patient on taking a nutritionally balanced diet. I will encourage my patient to join and be in touch with fibromyalgia associations for support. Now, for my follow-up plan, I will ask my patient to return to the clinic in 3 months for follow-up and reassessment. And if there is need to call the clinic, she should do so, especially if she begins to experience adverse effects from the medications, or if the symptoms get worse, or the medications are not improving her condition. These are the references that I use for this study, and I hope they will be helpful to you in your practice. And with this, I want to say thank you for listening.